This is the first of 4 podcasts about cardiac dysrhythmias and basic cardiac information regarding measurement of strips and identification of strips and basic EKG information. We're going to end the podcast with information about hypothermia protocol and those types of things, but no, I don't like that either. Scratch. This is the first of 4 podcasts regarding basic cardiac rhythms and dysrhythmias and interpretation of rhythm strips. So let's review a little A and P about the heart, because that's going to be important here. Okay? So remember that your heart is both an electrical system and a pump. All right? Obviously, we have talked about the pump before when we talk about cardiac output and congestive heart failure and those types of things. But it is also an electrical system. So that is what is represented on the telemetry strip and on the monitor that you see. Okay? So we're going to talk about a dysrhythmia where you will see an electrical beat or beats go across the screen, but the heart's not pumping. Okay? That's something called PEA, or pulseless electrical activity. It looks like the patient has a heartbeat, but they do not. All right? So a lot of dysrhythmias are due to electrical system failures, okay? And in order for your heart to work effectively, like it says, both the electrical system and the pump have to work together, right? So the electrical system is what stimulates the muscles to contract and relax and pumps the blood from the atria to the ventricles and then from the ventricles to either the lungs or the body. As you remember from A and P, there are multiple ion shifts, potassium, calcium, sodium, those types of shifts. There are action potentials that go across the cell membranes that initiate this electrical stimulus and cause muscle contraction. Okay? So if you need a review of that, I suggest you go back to A and P and take a look at that. All right? There are 3 different types of electrophysiology things that I want you to remember, okay? 3 different states of the cell, if you will. One is the resting potential state, okay? So they're ready to go. They're resting, but they're ready to accept an impulse, and they're ready to discharge that impulse and cause muscle contraction, okay? So they're resting and ready to go. Depolarization is when the cells get and respond to an electrical stimulus, okay? So those ions have crossed the cell membrane, and it makes the cell positive, and it receives and responds to the electrical stimulus, okay? So basically, it's doing the discharging here, the discharging of electricity. And then repolarization, I like to think of as the resetting, okay, of the cell. So it's the movement of charged particles to make the cell negative again. And then that's getting it ready to go back into that resting potential state, which makes it ready to receive and accept an impulse again. Now, during repolarization or the resetting, there's 2 different periods. And I want to make sure that you know the difference, and I have a little ditty to tell you to help you remember which one's which. All right, so there's the absolute refractory period where no matter how much the heart is charged, the heart will not accept another electrical impulse. Okay, so no matter how much electricity comes through that heart, it just will not depolarize again. All right. And then there's the relative refractory period. So that if you get a greater amount of electrical stimulus, then the cells will discharge again, but it takes a greater amount of electricity to do so. All right, so here's something that everybody knows. I'm going to compare this to flushing a toilet. All right, so when you flush the toilet, all right, that's depolarization. And when the tank is filling back up, the absolute refractory period comes about when you can push that handle as many times as you want to, and the toilet will not flush again. All right? But there does come a point when the toilet is filled up enough, or the tank is filled up enough, that if you push the handle again, it will flush again, not quite as forcefully as the first time, but it will flush again. That's the relative refractory period. Okay? So there you go. So the heart is compared to a toilet. Properties of cardiac cells. There are 4 different properties of cardiac cells that you should be familiar with. Okay? One is automaticity. Automaticity is the ability to initiate a response, okay, or to start it. Excitability is the ability to respond to the impulse. Conductivity is the ability to transmit an impulse. And contractility is the ability to pump as a response based on that electrical impulse. All right, now you know the term contractility from we talked about that with congestive heart failure. Okay, so automaticity initiates, excitability responds, conductivity transmits or conducts, if you will, and contractility is the pump action that comes about because of that electrical impulse. All right, so here's a very nice picture of your heart and the electrical conduction, which we are going to talk about here in a second. But here is your cardiac pacemaker, or your SA node, your sinoatrial node. All right, it goes down through the tract, and here's your AV node, down through the bundle of His and Bachman's bundles and all these kind of things, Purkinje fibers, and out into the cardiac muscle. Okay, so I like to think of it as a jolt and a bunch of fingers. Okay, they go down into the cardiac muscle, transmitting that electrical impulse to ensure that the cardiac muscle pumps in order to give us cardiac output. So here we go. So the conduction system, you've got your SA node, your heart's primary pacemaker, okay, generates an impulse 60 to 100 beats per minute. So, well, there you go. That's your normal heart rate, right? Move from the SA node through the atrial muscle. Okay, so the SA node causes atrial depolarization. This is called a P wave on the cardiac monitor strip, and I will show you that here in a little bit. And then the atrial cells depolarize, and the muscle contraction follows. Okay, that's the way it works, right? So that would be like your lub, if you will. Okay, so now you have your AV node. Okay, your AV node slows down the depolarization of the atria before it goes down to the ventricles. Okay, so this is the PR segment. So the P wave is the bump. The PR is the measurement from the beginning of the P wave to the beginning of the spike. Okay. This delay allows the atria to contract and the ventricles to fill. Okay. Now, this doesn't always happen. There are dysrhythmias that cause some interference, which, you know, can be a problem to a certain extent, but it's not usually life-threatening. All right. So moving on down the line, we've got the bundle of His. It connects the distal portion of the AV node, and it goes through the intraventricular septum. Okay, and it goes off into the right and left bundle branches. They go down through the left and right ventricles. Okay, and then you've got Purkinje fibers. Purkinje fibers are the end of the left and right bundle branches, and they are responsible for that rapid conduction of electricity or the impulses through the ventricles, and it leads to ventricular depolarization and then ventricular contraction. So you've got SA node, atrial depolarization and contraction. Down through the AV node, the bundle of His and the Purkinje fibers, which lead to ventricular depolarization and subsequent contraction. All right, so we're going to talk about some basic things related to cardiac assessment. And then in the second, third, and fourth podcast, we're going to talk about the dysrhythmias. All right, so if you've ever seen a telemetry monitor, and if you haven't, then when you go to clinical next, you need to make sure and look at this. You're going to see things that look like this. Or, you know, when we're in sim, if you ask me, I'll be happy to show you on the monitor as well. Okay, so here's the P wave. Okay, so that's atrial depolarization. Okay, and then the PR interval is from the beginning of the P wave to the beginning of the QRS. Okay, that is that slowing down period when it gets to the AV node. Okay. The QRS is ventricular depolarization, okay, and cardiac squeeze, if you will, cardiac contraction or ventricular contraction. Okay. And then the T wave here is ventricular repolarization. That's when the heart resets itself to go again. Okay. Don't worry about the U wave for right now. The U wave only pops up when we've got electrolyte imbalances going on. Okay. So the PR interval is atrial contraction. The QRS is ventricular repolarization, or ventricular depolarization. And then the T wave represents ventricular repolarization. Okay, so we've got the P wave is atrial depolarization. The PR is depolarization and repolarization. The QRS is ventricular depolarization. And the T wave is ventricular repolarization or resetting. Okay. Now, there are different numbers and things that you're going to have to know for this. So just keep in mind. All right, so there's atrial depolarization. PR is from the SA to the AV node. QRS is ventricular depolarization, and T wave is ventricular repolarization. All right. So, what is an EKG? All right. An EKG, or an ECG, if you will, is a picture, a 12-lead picture of the heart. So we're looking at the heart from 12 different views, and basically we do them to make we're looking for heart attacks and things when we're actually looking for them in the first place. There are different systems, but usually we will do a 12-lead EKG, okay, or ECG. So it is a picture of the electrical activity of the heart, okay, because it's going to look something like this, hopefully. We can do multiple leads or views. When we do regular telemetry monitoring on our patient, we usually do a five lead. We can do a 3 lead as well, or a 12 lead, which is when we hook them up to all the different wires and take a look at the heart. We can also take a look, do the right-sided EKG, which we put actually the leads on the opposite side, and we can get a picture of the way the right side of the heart looks in case we're considering that the patient may be having a right-sided MI. Okay. So here you go. So we've got 6 limb leads. We've got ones that are placed on the arms and ones that are placed on the legs, and then the other 6 are chest leads because they're placed on the chest. An ECG is a one-time picture. Okay, it's a snapshot of what's going on at the heart at this time. So going back to our treatment of someone with angina, all right. Remember we said about we can give nitroglycerin for our patient with angina. Well, that's great, but if the patient's truly having an MI and we give them nitroglycerin before we do the EKG or the ECG, then as the vessels dilate and the heart gets more blood and the pain goes away, then we're not going to get the same picture as we will for someone who is actively having angina and we do the ECG first, okay? So this is why we must always do the ECG prior to the administration of nitroglycerin, okay? Because it's a one-time snapshot picture, all right? So we want to get the picture of what's going on with the heart while the patient's having the chest pain, because that's going to give us a true picture of what's going on with the patient, as opposed to once we give them nitroglycerin, then we take a picture and it looks so much better. So we're like, oh, the patient's fine. Well, they're not, okay, but we did it in the wrong order. So this is crucial, and this is why we have to do it this way. All right, so this is just showing you different limb leads and things, so you don't have to remember this, but there's white, black, and red are the 3 leads. Okay, so white on the right, and then smoke over fire. So smoke is the black one, that's on the left arm, and the red one is down on the left leg. Okay, just that's how I remember it. All right, there are other ones. Like I said, you don't need to know. When you go into a hospital setting and you take a telemetry course and an EKG course, then you will learn all about this. But this is not the place. This is just to introduce you to the fact that there are different types of limb leads and different views that we can take of the heart. Okay, so there's also chest leads. And then here's what an EKG looks like, or an ECG looks like. All right, so usually it'll tell you a whole bunch of different things that we don't really pay much attention to, but we can take a look at it. Okay, sinus tachycardia, because the rate's 116. It'll tell you about a left bundle branch block, and you can take a look at some of these leads here and notice that they look notched. Okay, this one. We call them rabbit ears. All right, this one down here at the bottom. So that's a bundle branch block, and basically that means that when you've got ventricular depolarization, where the electrical impulses are going down through the ventricles, they should go at the same rate. Okay? When you've got a bundle branch block, it basically means that somewhere along the line the electrical impulse got stopped and it had to reroute. Okay? And that's what gives you that notched look at the top of the QRS. Okay? People live with them every day, but you know, it could indicate an issue, especially if it's something new. It's something to at least investigate for the patient. Alrighty. For continuous monitoring, for the patient who has having telemetry, we use a 3, 4, 5 lead system. Usually in most hospitals it's a 5 lead system. We don't put them on the limbs because of movement would cause artifact and funky rhythms. False funky rhythms, if you will. So the leads are placed on the torso. And there's that white on the right, smoke over fire. Okay. And usually it's right arm, right leg, left arm, left leg, and if it's 5, then we put one in the middle. That's the center, or the chest lead. Okay, so there's 3, there's 4, and there's 5. Okay. All right, so measuring the ECG. Like I said, we're going to get to the point here in a slide or two where I'm going to tell you, actually it's on the next slide, I believe, exactly the numbers you need to memorize, okay? But EKG strips paper looks like this, all right? We've got the big dark boxes, and then in those boxes, we've got teeny weeny little boxes, okay? So a big box like this, okay, is 0.2 seconds. And then there's 5 little boxes in each big box, and those little boxes are 0.04 seconds apiece. All right, so that's something that you need to know. When we measure strips for any testing purposes, they will usually be 6-second strips. Okay, so it'll be 6 seconds long. So I count them like this: 2, 4, 6, 8, 1 second. Okay, 0.2, 0.4, 0.6, 0.8, 2 seconds. 0.2, 0.4, 0.6, 0.8, 3 seconds. Okay, so every 5 big boxes is 1 second. Okay, just so you know, and we'll practice this. Okay, this is kind of why I gave you a podcast on this, so you can kind of come back to this if you have questions. All right, so here's just another representation that each big box is 0.2 seconds. 5 of these big boxes is 1 second, and each teeny weeny little box is 0.04 seconds. All right, here are the normal intervals that you need to know. All right, PR interval, okay, from the beginning of the P wave to the beginning of the QRS is 0.12 to 0.2 seconds long. A normal QRS from the beginning of the QRS to the end of the QRS, right, is 0.04 to 0.10. Should be very narrow. The QT interval, okay, from the beginning of the QRS to the end of the T wave, should be 0.36 to 0.44. Now, the slower the heart rate, the longer the QT interval is, all right? And that doesn't necessarily mean that it's abnormal, and there's a conversion that that the cardiologists figure out to determine whether or not the QT interval is correct for the heart rate, okay? So just understand that. So those are the 3 sets of numbers that you must be familiar with, all right? Anything outside of these numbers is considered abnormal, all right? And we will refer to these numbers over and over again in the next couple of podcasts, all right? So you must memorize these. All right. Like I said, any strip that I give you for testing purposes, or that you will get on NCLEX, will be considered a 6-second strip. All right, and we tell you that because that's going to determine how you figure out heart rate. Okay, it's really simple. So if it's a 6-second strip, you count the number of QRSs or spikes on that strip. Right, 1, 2, 3, 4, 5, 6, 7, 8, and then multiply times 10. Okay, because there's 10 6-second intervals in a minute. Right, so 1, 2, 3, 4, 5, 6, 7, 8. Times 10 is 80 beats per minute. And there you go. Now you can figure out any 6-second strip and figure out how fast the patient's heart rate is. Okay? And if you look at this, then you see you've got a P wave, okay, in front of every QRS. Right? You've got a nice narrow QRS, so if you measured that, it would probably fall in the normal limits. And then you have a nice T wave after every one. Okay? So this is normal sinus rhythm, but we'll get to that in a minute. All right, so there are 6 steps to analyze a rhythm strip. Okay, so step 1, determine the heart rate. Okay, is it fast? Is it slow? Is it within normal limits? Remember, normal limits is 60 to 100 beats per minute. 2, is it regular or irregular? Okay, so we can measure the distance between each QRS, okay, and determine if it's regular or not. And we're going to go over this with each different dysrhythmia. Okay. 3, you got to look at the P wave. Okay, is there P waves present at all? Okay, do they all look alike? Is there one for every QRS, or are they funky looking? Are they upside down? Do some QRSs have them and others do not? Does it look like there's a whole bunch of P waves and only a couple QRSs? Okay, so look at the P waves. That's your next step. Step 4, measure the PR interval. Okay. Step 5, measure the QRS. And step 6, measure the QT. Okay. And then analyze the rhythm. Okay, you got to put all the pieces together. So I'm going to have a chart for you that you can put all these things on so that you can study them. I highly recommend that you make flashcards or use the chart or do whatever you have to learn the difference between these rhythms. All right, it's a lot, I will tell you, but you know, we're going to practice in class, and I'll help you out as much as I can. All right. So then, analyze the rhythm. Normal or abnormal? All right. So is it normal sinus rhythm or is it some kind of dysrhythmia? And when you are asked about analyzing a rhythm on exams, you need to identify the rhythm. Not whether it's normal or abnormal, not whether it's regular or irregular, but what the rhythm is. And then I just put together this little algorithm to help you if you want. If not, you can disregard this one, but normal sinus rhythm is the gold standard, okay? So then you go, and is the rate fast or slow? If it's fast and regular, does it have a narrow or wide QRS? These are the things that it could be. Is it irregular, narrow or wide? These are the things that it could be, okay? If it's slow and regular, these are some of the things it could be. If it's slow and irregular, these are some of the things that it could be, okay? So it's just to give you an idea about where you might be thinking about going, depending on whether the rhythm is fast or slow, and regular or irregular. And then you have to take a look at the QRS as far as it being narrow or wide, okay? So like I said, it's just one of those slides that is for your use if it's something that you think that might be helpful for you. And this ends the podcast for basic ECG interpretation.